Good afternoon. This is Dr. John Bennett broadcasting from sunny Miami. Today we have a really good show on Neurosurgical TV. We have Samar Hoz. He's a 6-year neurosurgical resident from Baghdad, Iraq. He's going to talk about missile injuries to the brain from the years 2004 to 2008, and it's a pleasure to have him. And before I introduce Samar, let me introduce the panel. Hello, Bernardo.
Hello, I'm Bernardo de Andrada from Rio de Janeiro. I'm neurosurgeon, and thank you for inviting me for participate to this discussion.
Yeah, thank you, Bernardo. He's a real regular. And Fred, welcome back.
Hi guys, it's been a long time, but I'm really glad to be back, and I'm really excited for this hangout.
And Fred, you're a medical student, correct?
Yeah, that's correct.
What year? Third year?
Fifth year.
Fifth year. Okay, very good. And our old regular Simon.
Hello, everyone. It's always a pleasure to be here. I'm a medical student. I'm actually in Japan at the moment, a psychologist and also a neurosurgical enthusiast. So always wonderful to be here. Looking forward to this.
Welcome, Simon. And Slaven.
Hello, my name is Slaven Gojkovic. I'm a medical student from Croatia. I'm currently in Zagreb, and I am a member of various neurosurgical societies, student type, and I lead some programs that are trying to bind students interested in neurosurgery.
And a real neurosurgery lover. Okay, Samar Hoz, so welcome.
Welcome, sir.
Could you please introduce yourself and what you do, and then go on to your presentation?
Of course. Hi, sir, and hi, all panel colleagues. For now, I am Samar Hoz. I'm in final year, 6th-year neurosurgery resident. I'm practicing in neurosurgery teaching hospital in Baghdad, Iraq.
Very good, Samar. And can you start your presentation, please?
Yes.
We need some music playing. Okay. Very good. It looks great.
It's okay now?
Yes, looks great.
So, shall I start?
Yes, please.
Yes. Our talk today is about the predictor of outcome and penetrating craniocerebral missile injury in Baghdad, Iraq from 2004 to 2008. It's the study based on the neurosurgery teaching hospital from Baghdad, Iraq. I am Samar Hoz, and I'm final year neurosurgery resident in this center. Starting with introduction of the craniocerebral missile injury, by definition, it includes all types of projectile injury to the skull in general, or maybe to the brain specifically. The craniocerebral missile injury is a broad term, include both bullets and shell with low or high velocity. For the bullet injuries, there are too many classifications. One, and with the most practicable, is the according to the mechanism of injury. They divide the penetrating head injury or the craniocerebral missile injury to the head with the bullet into 5 types, as shown in the figure. The most common types are shown in figure B and C. For figure B, we can see the penetrating type of head injury, means that the bullet will hit the skull and penetrating the both table, inner and outer table, and then causing brain injury without exiting from the brain. So this is a penetrating type of bullet injury. The second type, which is also a common type, called perforating bullet injury, when the trajectory crosses both sides of the skull, where the bullet enters the skull, causing brain injury, and exit from other side and leave the body. So we call it perforating bullet injury, and actually in practice we call it a through and through injury. Other types, which are less common, example is tangential bullet injury. Tangential means that the bullet just hit the skull and continue the trajectory away from the body, while hitting the skull, it may cause depressive fracture to the skull and localized or maybe generalized injury to the brain, either contusion or hematoma. So this is for tangential. Other type is called ricochet. Ricochet is summarized by a double trajectory, while the bullet entering the skull, passing through the brain, hitting the inner table from the other side, and passing again to the brain and settle in other part, while causing a further injury to the brain. And this is for ricochet with double trajectory. So usually we see it in the brain CT scan when the bullet settled very far from the trajectory of entry of the bullet. We call it ricochet. The last type, which is a rare type called careening. Careening derived from crown, which is the shape of trajectory of bullet after crossing the inner table, outer table, then inner table, then dura. But here the bullet will not enter the brain. Instead, it will continue to run in the subdural space, just beneath the skull. If it's clear now, so we call it a careening injury. For the craniocerebral missile injury, is the slide changing, sir?
Yes, it looks good.
For the craniocerebral missile injury, have traditionally been viewed with pessimism due to their supposedly poor outcome, while their incidence is rising all over the world due to the rise in ethnic armed struggle, militancy, terrorist-related violence, and also to the easy availability of firearms. Nevertheless, mortality due to this injury remain high. A fact should be borne in mind in those who attend on victim of craniocerebral missile injury. The literature on missile wound sustained during war is more extensive than on peacetime for sure, and each war has further experience in this regard. This is the role of each war and how it add to the field of management of craniocerebral missile injury. The aim of our study is to document the craniocerebral missile injury in Iraq in the era after 2003 and to identify the predictor of outcome in penetrating craniocerebral missile injury according to the medical Iraqi resources, and also to update the data on the craniocerebral missile injury, as the struggle in Iraq is the leading cause of the continuous cases of missile injuries. For patient and method, the analysis of the craniocerebral missile injury cases presenting to the Neurosurgery Teaching Hospital in Baghdad, Iraq, between January 2004 and December 2008 was taken up prospectively and retrospectively. After 2003, you know, there is the civilian injuries reached the maximum due to terrorist attack from Al-Qaeda and then the Iraqi civil war. Predictor of outcome of these patients are assessed in terms of demographic data, clinical and radiological feature, and management strategy and outcome. Yes, the total number of our patients, including in the study, is 3,800 plus 2 patients presented to our hospital with the craniocerebral missile injury for the mentioned period, for the 5 years from 2004 to 2008. Yes, it's 3,800 plus 2 patients. Unfortunately, these numbers included only in the demographic data, and we exclude about 1,000 patients from further analysis of surgical approaches and surgical predictor of outcome because of incomplete or missing data. The transportation at the time of the study of most patients was neither proper nor quick, and mostly there were no field resuscitation. The surgical procedure were undertaken after complete assessment of the baseline investigations, neurological and hemodynamic status of the patient. All types of surgical technique, from minimal debridement to wound closure to standard and also radical procedure like craniotomy, and removal of accessible and visualized bone debris metal fragment, and hematomas. This slide shows the 2001 guideline for the management of penetrating brain injury, which is still the accepted guideline for the management of such cases. It includes the main line of management like antibiotic prophylaxis to prevent infection, seizure prophylaxis to prevent seizure as appeared, intracranial pressure monitoring, management of CSF leak, neuroimaging in the acute setting, surgical management, and the option as we tell, and the complication in general and vascular complication specifically. What is interesting in this guideline, if you see the recommendation level, all are optional, means that all are level 3 recommendation. So we used to these guidelines in the management of our patient in the study and in our center, but the recommendation level will show what we used to do is to individualize the guideline according to each case specifically. So we can modify the guideline according to the case. Each case will have its guidelines. The general result of our study for this big number, the total mortality during hospitalization is 64.6%. The gender incidence, the most commonly male affected by 76%. The mortality shows the opposite, where the female gender higher mortality than the male gender, and the age is usually around 30. If we combine the mortality and gender, mortality for gender and age, we will find that actually we classify the patient with the 45 years as a cut line, and we find that the male patient has more mortality when their age above 45 years, and female also more mortality above 45 years. For Glasgow Coma score, scale score, after resuscitation, of course, the associated mortality with for a patient with the Glasgow Coma score for 3 to 5 is 98%, while it's only 32% for patient with the Glasgow Coma score of more than 9. Also, the study includes the intracranial hematoma that usually found on CT scan, and the most common intracranial hematoma found was the subarachnoid hemorrhage with 84%, then intracerebral hematoma, epidural hematoma, subdural hematoma, with the mortality for the mentioned type of hematoma cannot be estimated individually because usually they occur in combination 2, 3, not as a single type of hematoma for each patient. The incidence and mortality for intraventricular hemorrhage is 27% for incidence and very high mortality rate for patient with associated intraventricular hemorrhage with 98.7%. The management plan, around 60% of patients treated conservatively and 37 undergone surgical intervention. I would like to present some of our cases. The first case is a victim of bullet injury, 18 years old male. We can see the preoperative, the inlet wound with the brain tissue coming out, which is one of the indication of surgery, of course, and intraoperative picture showing the bone defect and the brain herniating out from the wound. And also we can, if we follow the brain CT scan carefully, you can see that the inlet causing depressive fracture, and the bullet here like take a careening trajectory, as we said, running in the subdural space and stay just beneath the skull while causing injury elsewhere. So in this case, we do two separate staged surgery. First, we do urgent surgery for debridement and for this open depressive fracture, and later there was a hematoma around the bullet, and we do another surgery to extract both the bullet and the hematoma. Case number 2, the victim was 32 years old male, presented with blast injury. This is the shell shown in the brain CT scan. This is bone window CT scan and the brain window CT scan, showing the skull beneath the, showing the bullet, sorry, the shell beneath the skull, and the intraoperative picture showing how dirty the wound was in the surgery. There's a lot of debris within and that require urgent debridement. Case number 3, the victim was unfortunate 9 years old female as a victim of blast injury. Actually, the case referred to our center from other centers. That's why she take many X-rays. In our center, we don't usually recommend an X-ray. We start with the brain CT scan directly, and the X-ray shows big bone defect, a shell in the occipital part, and multiple fractures within the skull. Also, the brain CT scan showing there is no intracerebral or intracranial shell, only bone chips, aerosteel, and contused brain. And I think this occipital shell and the small one remain in the scalp, and the large one that caused the defect get away from the body. If we change to the intraoperative field picture, we can see the operative field, and we are trying to close the dural defect with artificial dura, as you see. Case number 4, the victim was 46 years old male. This is an example of tangential bullet injury where we cannot see a metallic part in the brain CT scan, so the bullet hits the skull like there and get away from the body and causing underneath a depressed skull fracture with underlying brain contusion and hematoma. This is the intraoperative picture, also showing how the brain is contused from the bone defect. Case number 5, which is the case for the last, the victim was 33 years old male. He's a victim of gravitational bullet injury. If you know gravitational means that that the bullet is not directed to the victim, it's directed away and get to the victim by gravity. And this picture shows the inlet, which is near the midline, which is the danger zone for us and as a neurosurgeon. This shows the intraoperative picture showing the field with the bullet stuck in the skull, and this is after further steps in the surgery. We do a craniectomy around the bullet so as we can get control of all sides of the bullet before bullet extraction, because it may contain a hematoma or something inside. And this is the brain CT scan showing how close proximity of the shell to the midline and how close to the superior sagittal sinus. And you know that the superior sagittal sinus, especially at that position, which is the around to start the posterior third of superior sagittal sinus and causing hematoma, so it's very dangerous. So require a perfect or entire surrounding of the bullet site by craniectomy, then start to extract the bullet. Case number 6, the victim was 45 years old male. He's a victim of bombing car. It's blast by a vehicle, and there is a fragmentation. It's a big shell there stuck in the head, and this is the X-ray show how big the shell and the intracranial part. And adding to this risk of this case is the proximity to the midline and proximity to the torcular, where the venous sinus confluence located, and also proximity to the transverse sinuses. This is the intraoperative picture showing how big the fragmentation, the metallic fragmentation, and how it's stuck in the skull, and this is the shape and size after extraction. For conclusion of our study, the craniocerebral missile injury are common in the male are more affected. In general, the mortality is higher in female, and the mortality is at highest level at female above 45 years old. And the admission Glasgow Coma score is the single most important prognostic factor in predicting outcome of craniocerebral missile injury. One of the recommendations of our study is to do a prospective study for the present and the future cases. We actually start in this study and put a detailed questionnaire that hopefully can capture all the data can be taken. You know that we manage both a mixed cases between civilian and military cases, especially in blast. You cannot recognize which military, which civilian. So we put a detailed questionnaire, include all these items, and it includes at least 26 variables to assess in the craniocerebral missile injury. Thank you.
Oh, okay. Okay, thank you very much, Doc. I appreciate it. That was a fascinating presentation. Now, obviously, there's a lot of trauma in Iraq, and I'm glad to see Bernardo's here because Bernardo was from Rio de Janeiro, and there's a lot of violence there. And Bernardo, you want to start things off by discussing the cases, please, and the presentation?
Very good presentation. Congratulations, my friend. And there are something I would like to thank you to comment. Thank you for sharing your experience. And I'm totally astonished with the high number. You know, 3008 is in 4 years is very high number. And I would like to know when you do not indicate a surgery due to poor prognosis, when you have 3 points in Glasgow scale and bilateral midries, we know that these patients would not improve with surgery. And can you tell me something about your experience in these cases?
Okay, thank you, Bernardo, for the comment. And there is 2 points. The first, the study includes 5 years, and our center is the only neurosurgical active center at that time in Baghdad. And you know, Baghdad received not only the Baghdad people, also the governmental area around also sent patients to our center. It's a pure neurosurgical center. This is for the high number. It's I know it's not easy to get. And for the I think you said it's when you do not do surgery, and I will answer in another way. We have no guideline when do not do surgery. We have guideline what's the indication of surgery, and it's clear that low Glasgow Coma scale score is not one of the indication. Glasgow below 5 is not an indication for surgery, of course, unless there is big extraaxial hematoma.
Okay, thank you so much. And another thing that I would like to know in your experience is about complications. I see a lot of gunshot wounds, and I see very complications after surgery. Unfortunately, it's very common we have a CSF leak and infections and seizures, and what can you say for us in your experience, in your huge experience? What complications you see more? Thank you.
Okay. Actually, we with this number you can see all complication, and I think there is a second enemy after the injury itself. There is a secondary injury, which include all types of affection of the brain and also include electrolyte abnormality and also what you point for, which is the post-surgical complication. And we know that if the patient past the initial injury, there is still a high risk for all complication, maybe CSF leak, which is may predispose later to infection, and also there is pseudoaneurysm, which is a rare cases, but there is reported cases. There is يعني a brain tissue leak, not only CSF leak in some cases. There is some cases that you do it urgently because of low Glasgow Coma scale, so you are in hurry within the surgery, so or you may cannot close the defect properly within the first surgery, so usually we have some cases that we do a redo surgery to close the defect, maybe not only for the CSF leak, maybe for a brain tissue exiting out.
Yes, I think CSF leak, infection, and seizure is the most common complications in this case.
Totally agree.
Another question. You usually perform a decompressive craniectomy for gunshot wounds, and obviously in some cases we have hemispheric hyperemia. Some patients can improve with this compression.
Actually, with the yes, I get your question. Actually, with the large frequency of cases that we do, there is no, if you call it a tendency to do decompressive craniotomy for non-lesional cases, for hyperemic case or maybe large infarction that cause a midline shift. We usually have no preference to do such cases. We usually wait unless it's clearly indicated to do.
Okay, thank you so much for your answer my questions.
Much appreciated. Thank you for your question.
Sam, I have a question from a general doctor, from an ex-emergency doctor. When you have a patient with a gunshot wound to the head, they call a neurosurgeon, you do a brief exam. How important is it to get a CT? Do you get a CT right away, or do you request the doctors to have the CT done before you come in, or do you kind of wait to see how the patient is and then go to the CT?
Okay, it's a good question, sir. Actually, if we want to answer this question, we can put the CT in its title. It's an investigation rather than a part of the actual management of patient. So first, of course, we should do the acute resuscitation, which include the ABCD, and then to assess the Glasgow Coma scale score and to assess the breathing state, which is very important to us. If the patient needs intubation, if the patient needs urgent correction of volume status, all are important more than CT scan. And after resuscitation, we can assess the Glasgow Coma scale score, and if the patient has a Glasgow score of 3 or maybe 4 and with non-respiratory drag on complete ventilation, we usually not recommend a brain CT scan in such case unless there is an improvement in the consciousness.
Yes.
Thank you. Thank you. Go ahead. Go ahead.
So yes, I think the CT scan in gunshot wounds to the head should be done very urgent. You should only access the airways and breathing and blood pressures and just assess the Glasgow scale, pupils, and CT scan. No
Oh, right
more
away. Right away.
anything to do before. Yes.
Okay.
Yes.
Okay. Fred,
But of course,
Simon.
after the
I'm sorry, go ahead.
Can you please tell me, I have a question, how many other injuries of the head can you see in such aggressive environments? I mean, when there are some collisions and when there is violence on the streets, how many other types of injuries have you seen despite gunshot wounds? And can you comment on the treatment of this? Which are the most common?
Okay, nice question. Actually, our center, as I said, is a subspecialty center. It's a tertiary center for neurosurgery only. So we receive two type of cases, either head injured cases directly or referred from other hospital, other general hospital after stabilization of other system, if you want to say. And if the other associated injury other than head injury, I think this is what you're questioning about. It's about according to how severe these injury are. If the patient has a severe head injury and there is multiple other wounds or superficial shell in the abdomen, multiple maybe small maybe fractures and distal fracture in the limbs, we usually accept this patient and manage it in the neurosurgery hospital. But in polytraumatized with other systems more effective than the neurological part, so we want to prefer to multi-system center or multi-specialty center.
And to which state, if you can hear me, to which state the prognosis is okay? Can patients regain some, do not have too many neurological deficits, depending on the GCS, when they have these wounds? Which I did not notice, which was the threshold of the
Yes.
GCS? Can you comment on this?
So the general cutoff of Glasgow Coma Scale score is number 8. If Glasgow Coma score more than 8, so it's maybe of a better prognosis. If below 8, it may be of bad prognosis. You know, but it's not a single factor thing. It's a multifactorial.
Okay. Simon or Fred, do you have any questions or comments?
Yes, thank you, Samir. Thank you very much for your presentation. I was very taken aback by the cases, especially the little girl. I was wondering, I have two questions. How did she do, that young 9-year-old girl? And the second one is regarding the guidelines that you mentioned were optional. How fast do those guidelines change, and what does it take to change the guidelines? Is it something that you might change in a day, or would you find out from an international journal? I mean, how long does it take to change those guidelines? Thank you.
Thank you, Simon. For the guideline, if you notice the date of guideline, it's of 2001, and the cause is the unexpectedness of the trajectory of the type of injury and this sort of cases. You know, it's unexpected. It's okay. It's a bullet injury, where it enter, where it exit, where it settle. So the guideline is to individualize the case. there is a general guideline which include only options, and you choose your priority according to the case.
I see. Thank you. And how did that 9-year-old girl do?
Actually, I put the cases that stay alive.
Okay.
Okay.
I have another question, but it's not directly connected with this theme, with this topic. You have the experience in cranial trauma, so I would like to ask you, when you have the acute subdural hematoma or hyperacute subdural hematoma, I have been reading some works of professors from Sarajevo who said that most surgeons do the horseshoe-shaped incision of the dura. But he says that this is not okay because you can have the incarceration of the brain due to the increased ICP and the edema that occurs. So which type of incision would you recommend in using? He recommends the L-shaped incision because of the less tensiveness of the dura, like a membrane. If you break the membrane, it is not so tense. So can you comment please on this? I'm very interested in your opinion. Thank you.
Okay, thank you. Actually, you are talking about acute subdural hematoma, and I add to your question, in case of brain swelling, it's the same condition when you open the dura, how to open. Actually, the answer is that's the surgery. The rule in surgery is no rule. It's your judgment, it's your experience. We usually open the dura in a star shape fashion or a cross shape fashion, and while closuring the dura, this is the time of judgment. You can sometimes leave the dura if the case cannot take more time within the surgery. Sometimes we do a patch from other side, from the pericranium, to close the dura and usually suture it loosely on only the angle. And sometimes we use a fasciolata from the lower limb, which is open while I done the surgery in the head. My colleague open the lower limb and take a fasciolata to facilitate easier closure, and it's still optional. Also, and the rule is to leave the dura closure as bogey as you can. Bogey mean to leave a space for the brain to contain the expected edema that will occur.
Thank you. I asked some other neurosurgeons from Croatia this same question, and I was interested just in your opinion, and it is quite the same. So thank you. Their answer was the same. You don't need to have you design your opening during the operation. So thank you very much. If I understand.
Yes.
Thank you.
Yes, Sam, I have a question regarding foreign bodies. In medicine, sometimes it's better to leave the foreign body in if in fact that you'll cause damage trying to get to it. Are there any cases, what cases in penetrating missile injuries do you consider just leaving the fragment in? And when do you decide that?
Okay, Simon. Actually, there is the rule is the opposite. When to extract the shell or bullet, not when to leave. There is only indication when to extract the bullet, because the natural pathway is to leave the bullet, because it will take time, and the injury while taking the bullet will be more than leaving the bullet itself at the position it's settled, unless there is indication for removing, like heavy metal poisoning, like accessible part, like accessible shell or bullet already within the field, like moving bullet within the follow-up radiographs when you do further CT scans moving, like near the ventricle or within the ventricle, that may cause hydro or opened into the ventricle, or maybe near the vessel, and it's questionable. You have to do a lot of preparation before you deal with a shell near a vessel.
Okay. Thank you, Doc. And Fred, you're quiet over there.
Yeah, I know. I'm just quite baffled about all these statistics and the cases. These are yeah. I'm afraid to say amazing because it's so terrible, but it's something we hardly see. We hardly ever see around these spots. So
Yeah.
yeah, it's quite amazing to see it. But it was a very clear presentation for which I thank you.
Much
Yeah.
appreciated, sir.
Excellent. Yeah, you know, I mentioned to Bernardo about how he likes the carnival, and he just shook his head and said, "Oh no, it's bad because that's when it gets violent, and that's when you have problems like this, right, Bernardo, down in Rio?"
Yeah, I usually see a lot of gunshot wounds to the head and to the spine too, because we have kinds of civil conflict, and my hospital is close of some of this neighborhood, and we have a lot of gunshots also to the head too. And about the dura opening, I always like to open like a star. I think it's perform a better decompression of the cerebral of the brain. And the other questions about keep the foreign body, I think that if the foreign body is deep, uh, we should not remove. But if it's easy to see and we can do if without uh, any damage to a vessel or a tissue, we could remove it. It will not change the prognosis.
Okay.
Just if the bullets uh, uh, cause some kind of seizure or infection, you know.
Well, I have a question directed to both neurosurgeons. Are there any indications on a patient's neurological exam that you'll say, wait, we better go in and get the fragment? Can you decide whether or not to be invasive just based on the neurological or worsening neurological condition?
Yes, Bernardo.
I
Or
actually,
do you base it on other factors?
oh, actually, I didn't understand well the questions. Can you repeat?
Well, yeah, sure.
I
Well, go ahead. Go ahead.
Yes, you are asking if during the initial assessment of patient and while we are examining the patient and if we find a shell or it's a victim of shell or bullet, whether to take a direct decision to extract it. That's your question, John?
More or less. Like, if you say you leave a fragment or a bullet in there, and the patient starts to deteriorate neurologically, do you ever consider, hey, we better go in there and take the fragment out to see if that would help the worsening neurological condition, or that's not a
I,
factor in your
I,
decision?
I think that only the presence of the fragments on the brain tissue did not justify the neurological deterioration. You should look for something that is causing this neurological deterioration.
Okay.
Maybe it could be a meningeal infection, a meningitis.
Right.
Maybe it could be there, and you consider to remove because this fragment, if this fragment has contact with the CSF fluid, is CSF fluid, you maybe it can cause in a meningitis and should be considered to remove. But you always should look for the cause, the exactly cause of the neurological deteriorations. The
Okay.
simple presence of the fragments on the brain, it don't justify this the neurological deterioration. I think I I I want to listen somewhere.
Okay.
Okay, I totally agree with you, Bernardo, and I can add something. You can imagine that the mechanism of injury to the brain while a bullet hit the brain include three types, and the least effect, the least injury to the brain came from the bullet tract direct. You know, there is a secondary injury. We call it a wave of the injury, the wave of the blast or the wave of the bullet. If you understand me, the sonic wave that causes brain injury, and if you want to imagine it, our text said it's a 20 time the size of the bullet tract itself. So in case of bullet within the brain, the injury is not within the tract and not within the site of the brain of the bullet usually. It's already the brain injured, and it's 20 times the size of the bullet itself. When you want to extract a bullet, usually not in the acute setting, if you want to extract the bullet per se, not for associated hematoma. And there is some indication to extract the bullet maybe later, if, as Bernardo say, if it's a focus for epilepsy, or it's maybe a focus for infection like meningitis, or maybe it's a focus for localized poisoning if it's a heavy metal.
Well, very good. And any closing comments, gentlemen?
Well, I would just like to continue just one thing that Dr. Bernardo said about the decompressive craniectomy. Which steps do you take when you have increased ICP to control this, and how fast do you go to decompressive craniectomy? Can you comment on this, please? Because I'm interested just because of this. How can you treat this condition? Despite decompressive craniectomy, which are conservative steps, and then when do you decide to go into?
Okay.
For summer.
Did you hear that? Did you understand that question, Samer? Did you hear it? Okay.
That's the question for Bernardo.
Oh, okay. I'm sorry.
The question is for me or Summer?
Well, if anyone wants to comment more, you asked this question
okay.
about decompressive craniectomy, so I just wanted to find out a bit more.
I think Bernardo is a lover for decompressive craniectomy, and he can answer.
Okay, whoever.
No. So I think we should always be attempt to pay attention if the patient has a good respiratory parameters, and I always try the osmotic therapy, and if it's not working, and the CT scan, if you have signs of intracranial hypertension, like losing the sulcus and homogeneous parenchyma, and we should strongly consider this compressive. But we always should remember that craniectomy, this compressive craniectomy, has a lot of complications, like infections and CSF leaks. Many times the bone flap in the abdomen acquire infection, and you should remove this bone and made a cranioplasty, and we should be measure how aggressive, how conservative we may be in sometimes,
Yes, I was asking this because I read some recommendations about this, that this is the last resort therapy for increased ICP, that there are no indications to do this except you have exhausted any other method of treating.
We should always try the conservative treatment first, like osmotic therapy and hyperventilation.
Maybe
And
barbiturates or
yeah,
Mannitol.
maybe also yes,
medications. Yes, thank
yes.
you very much. This is I just wanted to find out a bit more about this. Thank you.
If patient is correct under sedation, and the positions of the beds, if there are a 40-45 angle, you know.
Very good.
Thank you very much.
Okay, I'd like to wrap it up. Samar, I'd like to thank you for an excellent presentation. I think this is our most watched episode, and I invite you to give more presentations as well as your Iraqi associates. And thank you, Bernardo, for coming out and adding to the discussion. And thanks
Thank you,
to Fred.
thank you, Summer.
Thank you.
Thanks to Fred. Thanks to Simon.
Thank you
Thanks
all.
to,
Thank you all, sir.
and
Thank
thanks
you for
to
the
Slaven.
opportunity.
Thank you.
Thank you very much.
And we wish you just hang around. We're going to end up the broadcast, but good. Let's just say goodbye to the world.